Hello, I'm Dr. Sam Frank. I'm a neurologist at Beth Israel Deaconess Medical Center in Boston, and with me is Jody Goldstein.
Hi, everyone. I am the Director of Clinical Operations at the Huntington Study Group.
And we're here to talk about the upcoming Huntington Study Group effort to look at the virtual Unified Huntington's Disease Rating Scale. This is a study that is sponsored by HSG. It's being run by HSG, and it's really an adaptation of the original vUHDRS that was developed in 1996 with a revision in 1999. This is an extension of the HSG mission to do what we can to help develop clinical research for the HD community. This is, of course, a huge effort, and there are many people that are involved. And so Jody and I are just representing the many people on the steering committee. One thing I'd like to point out is that this is a rather unique steering committee in that we have some folks on the committee that have a personal interest in Huntington's disease, but are not in the academic or clinical research world. That's really because of the technology and security aspect that is so important for this study. Just to revisit some of the history, I know many of us here were involved in the development of this tool, and we all have used this tool, but there are always new members at Huntington Study Group. The vUHDRS 1996 is a copyrighted tool that was developed by HSG, and as you can tell by the videotape, which we don't use anymore, it's an older tool that has served us well and needs to be adapted for current times. During the development of the vUHDRS, it involved several months of pilot experience first, and this is from the manuscript that there was emphasis placed on clinical features that were likely to show rapid progression and on assessments that could be made during a relatively brief, meaning 30-minute examination. Neurologists, psychiatrists, neuropsychologists, and other professionals participated in the drafting of the final version. So similar to our current effort, there are multiple viewpoints on the development of this extension of our scale. This was a huge effort on the patient community too, and there were 489 patients that were involved in the development of the vUHDRS, and this is their baseline characteristics from that publication. I think that it's become very obvious in recent times that there are many situations in which remote assessment is required, not just preferred. And the pandemic is just one, but in the past, we've had other issues that have prevented participants from getting to sites, whether it's a hurricane, snowstorms, wildfires. I'm sure we've all had the participants that had some type of car troubles. And on the sponsor side, there's a drive to make sure that we can do remote assessments from a regulatory perspective. And of course, it would be great to get more frequent data acquisition without putting more burden on our participants. So how can we do this? Telehealth. And there has been some pilot data. This was published in 2014, but this was a very small study. This was prior to a lot of the technology that's been developed. I think we're all familiar with telehealth at this point, but that was not the case in 2014. And so the objective of the current virtual vUHDRS study is to assess the reliability of the virtually administered vUHDRS compared to in-person administration of the vUHDRS to establish the use of the virtual vUHDRS for clinical trial and regulatory purposes. Of course, this is something that this is a tool that we'll be able to use clinically as well. Jody, you want to talk about site selection?
Yeah, thanks so much, Sam. Choosing the right site is very important for the study. We plan to have all sites activated within a couple of months, if not sooner. We will include US-based sites as well as Advara-enabled or central sites. We're choosing experienced HSG investigators and coordinators, and then we'll also choose locations with urban and rural patients. Thanks, Sam.
In terms of the participants, we of course need something to measure, and so we want them to be motor manifest and anticipate that we'll need about 60 participants. We also want to be able to test the gait aspect of the vUHDRS, so they have to be ambulatory enough to take 10 steps, but they can use an assistive device. They have to be stable on their medications prior to and during the course of this observational study, and no active suicidality. Of course, they have to be able to get and maintain a satisfactory internet connection at home or their designated location where the study visit is going to occur with their own or with some provided equipment. This is through the internet, and we are not going to be recording. We did that on purpose for ease of speed. We are going to be providing a portal, and this is really for live assessment only. This is not going to be through smartphone, so it has to be a tablet or a computer. And if a computer or tablet with a camera is not available to participants at home, then they'll be provided with a MiFi and an iPad. Otherwise, they're going to be randomly assigned to either home-based equipment or provided equipment. This study is going to involve 3 main visits, I would say: a screening or baseline, which screening activities are going to occur, and then an in-person vUHDRS. They may or may not go home with equipment, but either way, there's going to be a technology check, and this is going to be centralized. And this is to make sure that there's a hallway, that there's a good setup at home, and that the internet connection is good. Then there's going to be a virtually administered vUHDRS. Again, obviously that's going to be remote, and that's going to be about 3 weeks after the in-person vUHDRS. And then about a week after that, they'll come in for a third visit, and that's an in-person vUHDRS. In terms of the analysis, our primary outcome measures are agreement of the total motor score at the second in-person and the total motor score via telehealth. We also want to look at all sections of the vUHDRS and agreement of the TFC independent scale functional assessment measures at the second in-person visit via telehealth. All the secondary outcomes are, of course, important as well, but the key is agreement of the total motor assessed by telehealth randomly compared to either the initial or the follow-up in-person visit. The safety of conducting the virtual vUHDRS remotely, and the feasibility and agreement of cognitive and behavioral sections of the vUHDRS in person and by telehealth. And the last secondary is the feasibility of completing the virtual vUHDRS using home-based versus provided equipment. In terms of the goals and what we plan to use in terms of the outcome measures, of course, the goal is to improve access to clinical trials, including the development potentially of hybrid trials to reduce participant burden, reduce costs for sponsors, participants, and sites. And we hope that HSG will provide an extension of our tool to make it available primarily for clinical research. This is an opportunity to provide consistency of telehealth and use of the vUHDRS over time to enhance its clinical use as well. This study really is to set up virtual use of the vUHDRS for future studies and for regulatory acceptance as well. And so with that, we will stop and take questions about this exciting development by HSG. Great, and we're back live. And so we're happy to take questions about this project that is getting up and running by HSG. And as the questions start to come in, we thank you for your time and attention today. There's been a lot of interest in this, as you might imagine, given the past couple of years in terms of how we practice medicine. And so Dave Sprecher made a comment/question. Conducting telemedicine who's using a desktop is profoundly frustrating. It certainly can be. I agree with you on that. And precludes completion of the gate portion. And that's true. I think that we need to have setup that is appropriate, not just the device that has the camera, but also the setup of where the participant is. And I know when I have a telehealth visit, when I see a wall right behind the person, that's going to be a challenge right there. But if they're in a living room or there's a long hallway, and that's why it's also going to be important to have a study partner along with the participant to help with the setup. That's going to be part of the technology check too, not just is their internet fast enough? Can we establish a connection and open up the app? But what's the setup from a logistical perspective as well. Okay, the questions are starting to come in. Are we collecting data on connection issues on the side of the patient? Absolutely, we are. This is a really important issue. Is it frustrating from the site and the participant perspective? And that's going to be really critical data that we need to collect related to the logistics of doing telehealth in this setting. So a really important piece of information to collect, and we have an opportunity to do that. Are we adding a version of the poll test? And that I would love, this is from Joel Perlmutter, we'd love to hear how you do that. We were actually going to not do this. And the reason is that obviously patients with neurodegenerative diseases, including Huntington's, have balance issues, and we don't want to create any medical issues. We do have a medical escalation plan in place, but there are certain aspects of the vUHDRS that are difficult to assess, and we don't want to increase the risk as well. So please message me directly. I'd love to see how you do that. Yeah. Any thoughts on how to provide a hotspot or other way for rural patients to access the program? And that's exactly what this is going to be testing out. We want patients who are in rural areas, who are in urban areas that may not have great signal as well, even though they have access to cell and Wi-Fi. We have a wide variety of sites that hopefully will bring in a wide variety of participants in terms of setting, and that was done on purpose. And so we're going to be providing some Wi-Fi to some of the participants. And as part of this as well, we're going to have good training for the sites. And again, that's an advantage of having this centralized. We are going to have technology checks, as I said in the slides, so that there's going to be a centralized way of getting participants and their study partners up and ready, as well as the sites in terms of what's going to be trained in terms of accessing the internet. Will we differentiate between urban and suburban subjects? Not necessarily. I think that we do want to get an idea where they are and what type of environment, but that was not an anticipated aspect in terms of our analysis. We wanted a variety of settings that are going to be realistic for both clinical and clinical research participants. And I think that we've done that. Are we going to be providing tripods to prevent subject movements from disrupting video? The cameras have to be stationary, and we have not gotten as far as providing tripods for people, but a stand to keep the video stationary. So that certainly can be provided if it's going to be needed to keep people steady. So that's something that we could consider doing. But certainly we're not going to have people.
Sorry, Sam. And I was also going to mention that we are going to be working with our team, who will work directly with the participant and caregiver to make sure that everything is in place for visits.
And I know who this is from. Will this trial be on HD Trial Finder for families to find once it launches? I certainly hope so. And we will work with our HDSA colleagues and friends to make that happen. I think that's an outstanding idea. And then is the virtual vUHDRS something that could be integrated into my HD story? That's not something that we have talked about. I think it's worth discussing. There are obviously two different projects with different objectives and outcomes, but always worth discussing, collaborating with our HSG colleagues. Well, we're running short on time, but we thank you all for your time and interest. It's really exciting to see that the HSG tool that's been around for so long is being moved forward into this century. And it's exciting to see that the HSG capabilities are moving forward for better use in clinic and through clinical research. So enjoy the rest of the meeting, and thank you for your time and attention.
Thank you, everyone.